Okay, this is Chapter 30, Ears, Part 2, and we're going to get started with acute otitis media. As you know, otitis media is an infection of the middle ear, and the AAP guidelines say that you need to have the presence of 3 of the listed components to be diagnosed as acute otitis media, and that includes recent or abrupt onset of middle ear inflammation and an effusion causing pain, irritability, drainage, fever, a middle ear infusion confirmed by a bulging tympanic membrane, and you may see that when you're doing pneumatic otoscopy that there's limited or absent mobility. You'll also see an air fluid level behind the tympanic membrane or drainage, and then signs and symptoms of inflammation, including distinct erythema of the tympanic membrane and painful. Be sure and look at Table 30-4 for the different types of otitis media. And then also with otitis media, you can see eustachian tube dysfunction. And that common causes of that include upper respiratory infection, allergies, and exposure to smoke. So with that tube dysfunction, you can have a functional obstruction or swelling in that area, and that decreases the ciliary's action to be protective of that ear canal. With that ear inflammation in the eustachian tube, then you have negative pressure that pulls the fluid back in, and that can accumulate and be a breeding ground for bacteria. And also in younger children, they have shorter, more horizontal eustachian tubes that aren't as firm as older children and teens. Common organisms seen are staph pneumonia, H. influenza, M. catarrhalis, and S. pyogenes. Viruses can often cause some of the symptoms of otitis media, but they are usually caused by bacteria or maybe a combination of bacteria and a viral component. Some clinical findings you may see include sudden symptoms, ear pain, pulling at the ear by the infant, irritability, drainage, fever. Some other factors that you need to consider when making your diagnosis: was this child premature? Are there any craniofacial abnormalities, any congenital disorders, any risk factors? If the little one is suffering from any lethargy, dizziness, ringing in the ear, or unsteady gait, if there's been a change in hearing, and also if there's a stuffy nose, runny nose, or sneezing. On physical exam, you're going to see a middle ear infusion. You're going to see bulging tympanic membranes. The color of the membrane is going to be less translucent. There's going to be absent or decreased mobility of that TM, and you will notice an air fluid level behind the TM. And there may be some drainage from the ear. With that middle ear inflammation, you may see redness of the TM, and then the pain that can interfere with sleeper activity. You may notice that the tympanic membrane has more vascularity to it, and there may be obscured or absent landmarks. It may take on a different color, such as a red, yellow, or purple hue to it. Also, the fluid behind the TM can take on a more straw-colored appearance. So, diagnostic studies that you might do with this patient include pneumatic otoscopy, which is the easiest and most efficient. The tympanometry, remember from our earlier section, evaluates the function of the middle ear by assessing the movement of the tympanic membrane. And then a tympanocentesis is an aspirate of the fluid and is going to tell you more about the organism, and that is something to refer for. And all of those, if you need to look those up again, are on page 738, the different diagnostic studies that you can do with ears. Some differential diagnoses for acute otitis media may include otitis media externa, mastoiditis, a dental abscess, sinusitis, lymphadenitis, periodontitis, peritonsillar abscess trauma, eustachian tube issues, TMJ issues, and immunodeficiency. If you have a little one that's less than 2 months old and there's fever that you cannot find purpose for, then that needs to be further evaluated. There is an excellent table on page 747 of the Blue Book, but it's table 30-5 that's titled Treatment Guidelines for Acute Otitis Media, and it breaks it down to the different scenarios that may be seen with otitis media and tells you whether to treat or to not treat. I encourage you to look at that. Also associated with this is pain management, and so you can recommend to parents the use of ibuprofen or acetaminophen, and if the TM is intact, there are some topical anesthetic drops that may be used, and then also distraction oils being applied externally, heat or cold. But this is also a good opportunity to review the child's height and weight and what dosage they should be on for Tylenol or ibuprofen, and make sure that the parent is aware of dosing, not just say give them Tylenol or ibuprofen. Table 30-6 and 30-7 have some really good information on medications to use to treat otitis media. Remember that the first line of choice is amoxicillin or amoxicillin potassium clavulanate. Amoxicillin is dosed at 80 to 90 milligrams per kilogram per day, divided into two doses. And this would be first line if there's been no ear infection in the last 30 days, no conjunctivitis, or no penicillin allergy. The beta-lactam coverage, if treated in the past 30 days, if there's an allergy to penicillin, concurrent conjunctivitis, recurrent otitis media that has not responded to amoxicillin, you would need antibiotic coverage. The beta-lactam antibiotics, I don't think I mentioned that, would be the amoxicillin, potassium clavulanate, third generation cephalosporin. If there's a documented hypersensitivity to amoxicillin, some of these other antibiotics on the screen can be used. If you had a child that was vomiting, ceftriaxone would be appropriate. Clindamycin if ceftriaxone had been failed and only if susceptibilities were known, and then prophylactic antibiotics are not recommended. Another form of management for the ear infection is wakeful watching. You can do this for anywhere from 48 to 72 hours. This allows the patient to see if improvement is noted without antibiotic therapy. It's important, if this route is chosen, that you make sure that there's adequate pain relief. There needs to be a conversation initiated by the parent or a visit if the condition worsens. They need to be scheduled for a follow-up appointment, not at the basis of what the parent thinks, but if you see them on Monday and they're going to do wakeful watching, then you need to see them again on Wednesday or Thursday. There needs to be routine follow-up calls by the office to check on these little, and then also providing a prescription to start if there's no improvement or worsening symptoms in the next 48 to 72 hours. It's key that you have the communication component, the ability to reevaluate, and the medications available if symptoms should get worse. So if you have persistent ear infection, even despite completing the antibiotics, and the symptoms are still there, or there's a recurrence within a few days afterwards, a broad spectrum antibiotic is recommended. We know that middle ear effusions are common, and antibiotics are not needed for these unless there's indications that there's infection going on. Recurrent ear infections greater than 3 in a 6-month period or 4 in a year period, with one of those being in the last year, would elicit a referral to an ENT, and when therapy fails. Just some things to remember for otitis media. It's important to keep up with new guidelines, and there's lots of different sources out there for being able to determine that. Decongestants and antihistamines are not helpful in the treatment of the infections. Antibiotic or antimicrobial or ophthalmic drops are indicated if the tympanic membrane is perforated, if there's drainage, or if the patient has draining ear tubes. Xylitol can have bacteriostatic effects, and it can come in lozenges and chewing gum. It mostly has those bacteriostatic effects against strep pneumoniae and interferes with bacterial adhesions to the mucous membranes. And in case you have parents that are wanting to try more herbal supplements, there's been no proven herbal supplements that are safe and effective. So some complications of otitis media: persistent tympanic membrane perforation, mastoiditis, cholesteatoma, sclerosis of the tympanic membrane, hearing loss, ossicle necrosis, pseudotumor cerebri, cerebral thrombophlebitis, and facial paralysis. It's important with these patients for prevention and education of child and parent, but it's encouraged to get the pneumococcal vaccine, annual flu shot, using xylitol gum or liquid if greater than 2 years old, exclusive breastfeeding if possible, up to 6 months, having licensed daycare with fewer children, avoid bottle propping, smoke exposure, avoiding pacifiers, and to educate parents, importantly, about drug-resistant bacteria and then how antibiotic use can impact that. So now next let's talk about otitis media with effusion. So the diagnosis of otitis media with effusion is made when there's evidence of a middle ear effusion without signs or symptoms of an acute ear infection. There are some good pictures on figure 30-6 through 30-9 in the book that show some great visuals of some different issues that can happen with and what you might see with an infusion. Remember that if you're having decreased mobility of the tympanic membrane, then you can very easily have issues with sound conduction, and your child, due to all this fluid behind their ears, their tympanic membranes may not be hearing as well as necessary. This can occur spontaneously with tubes or caused by inflammation from acute otitis media. It could be caused from viral infection. It can also occur with anatomic abnormalities, changes from flying, such as barotrauma or allergies. With otitis media with effusion, there are some changes in the middle ear mucosa that you'll see. There may be increased mucus production. It becomes much thicker, and fluid can get stuck behind the tympanic membrane. When you're taking a history, it's important to ask how have they been feeling, if there have been any issues noted, have there been any fevers. You can assess for if there's been any intermittent mild ear pain, any fullness to the ear, hearing loss in older kids, any dizziness or impaired balance, or chronic vomiting or failure to thrive. When you're doing the physical exam, you may note decreased tympanic mobility and being assessed by a pneumatic otoscopy. The tympanic membrane may be dull. It may be bulging and opaque to retracted due to the retraction. Your landmarks may be visible, but they may not be visible. Some diagnostic testing that you may do include a flat tympanogram, and you may see decibels of anywhere from 25 to 31, and that's indicating a hearing loss. Some differential diagnoses for this effusion are, of course, infection, any cause of hearing loss, persistent unilateral otitis media externa effusion may indicate a nasopharyngeal carcinoma. Care for these patients with this condition are following clinical guidelines of wanting to do a wakeful watching period. And for an effusion, that is a 3-month period. You need to have documentation of the effusion and any associated symptoms, hearing tests possibly, identification of children who are at risk for having learning problems, speech or language issues. You may need to refer. That may require having bilateral tubes put in. There's no evidence that decongestants, antibiotics, nasal steroids are of benefit. Histamines may be beneficial if there's an allergy component, and it is known that tonsillectomy and an adenoidectomy alone are not useful to help with the flow of the ear. Prevention and education are important. Follow up until the tympanic membrane or hearing returns to normal. Remember how important the role is of language development, and depending on what that is with the age of the child, be sure and assess for that. To maximize hearing, if you're concerned that the child is not hearing you as well, be sure and face the child, get within 3 feet of speaking, enunciate clearly, use visual cues, make sure that there's not any background noises that are competing in their ears for what you're saying. And if it's a child that's in school, request that preferential seating closer to the front of the room may help with hearing as well. Let's talk briefly about a perforated tympanic membrane, and this is most common with infection of the ear. You have infection, you have pain, and all of a sudden the pain is gone, and that usually happens after the pressure has been relieved from the rupture of the tympanic membrane. You may see quite a bit of drainage from the ear. You can also have traumatic tympanic perforations from blows, blast, improper ear cleaning, or a foreign body in the ear. Some clinical findings when you're going to assess for the history: you may not have any reported symptoms, but they may report whistling sounds with sneezing or some hearing loss. Clinical findings on your physical exam: you're going to perform an otoscopic exam, and you may see a lot of drainage that may obscure the tympanic membrane. The tympanic membrane may appear flat, and if so, when that has healed, then you can perform a hearing test to better assess. Some other differential diagnoses are OAM, the drainage that can be associated with tubes in place, and a non-accidental trauma. So for a ruptured tympanic membrane, you need to control for the drainage. Wakeful watching is important while it's healing. Medications, you want to avoid ototoxic ear drops and treat with an oto drop for the ear infection if that is present. During this time, there's no swimming or any water in the ears, and most perforations will heal within their own with about 3 months. Complications may include a recurrent infections or a cholestostoma. So let's talk about a cholesteatoma. It's usually as a result of chronic ear infections. It is a collection of epidermal cysts in the middle ear and the mastoid area, and has a lot of debris to it. It can be increased in size, and due to that increase in size, it may cause damage to the surrounding tissues. Infections, hearing loss, dizziness, and any facial muscle paralysis are rare complications. Some clinical findings on your history: you may note that they've had some chronic otitis media with purulent drainage. They may have vertigo, hearing loss, and a history of tubes. On physical exam, you may note that there's pearly white lesions on or behind the tympanic membrane. Differential diagnoses include tympanosclerosis, debris from chronic otitis media effusion, malignant rhabdomyosarcoma, and areal polyps. For this condition, it's important to make an accurate diagnosis and then have an immediate referral to ENT because there are other concerns as it grows that it can cause more damage. Complications might include irreversible structural damage, permanent bone damage, facial nerve palsy, hearing loss, and intracranial infections. So let's talk about mastoiditis. It's a suppurative infection of the mastoid cells and is often seen with acute otitis media. You will see inflammation of the mucoperiosteal lining of the mastoid air cells. Antibiotic treatment for acute otitis media does not prevent mastoiditis. It's uncommon, but it can be potentially life-threatening. It's also important to note that wakeful watching of acute otitis media has not been shown to increase the risk of mastoiditis. On your history and physical exam, you're assessing for any concurrent or recurrent ear infections, fever or pain, persistent otitis media, unresponsive to antibiotics, any post-auricular swelling. Some diagnostic tests that could help with further diagnosing the condition might include a CT or an MRI, and then also doing a tympanocentesis with culture. Differential diagnoses may include other post-auricular inflammations. Management includes an urgent referral to ENT. The child will likely require hospitalization, IV antibiotics, a myringotomy, and placement of tubes. Prevention includes, once again, reinforcing the pneumococcal vaccine that has been shown to reduce the incidence of mastoiditis. We have about 7 or 8 more slides, and I'm going to go on and finish that in this recording so you won't have to listen to a third recording. Our next section that we're going to talk about is sensorineural and conductive hearing loss. So hearing loss is defined as a bilateral pure tone hearing loss of 40 decibels or more at frequencies of 500, 1,000, and 2,000 in their better ear. There are 3 types. We have sensorineural, conductive, and mixed. So the sensorineural is associated with dysfunctions of or damage to the cochlea, and it can be congenital or acquired. It can be mild or severe, and it is permanent. Conductive hearing loss can be congenital or acquired. These kids are known to have a problem in the outer or middle ear. And mixed hearing loss is a combination of both. Both of these conditions can be associated with craniofacial abnormalities, genetic abnormalities, and environmental exposures or illnesses. Some craniofacial abnormalities may include cleft lip or cleft palate, external ear deformities, dysmorphic facial features. Some genetic or congenital deformities may include some cafe au lait spots, a familial history of the sensorineural hearing issues, metabolic abnormalities, and there can also be environmental issues as we talked about, and those may include ototoxic drugs, bacterial or viral meningitis, or other infectious diseases, loud noises, or head trauma. Some of this is a review of what I mentioned previously, but in your history, you're wanting to assess for birth weight. You're wanting to check to see if there was any depression at birth, if they were in NICU, prolonged mechanical ventilation, persistent pulmonary hypertension, congenital infections, metabolic disorders, craniofacial abnormalities, genetic syndromes, hyperbilirubinemia requiring exchange or connectosis, a family history of the sensorineural condition, or ototoxic drug exposure. Other things to assess in your history are what the parents' concerns are about hearing, if there's any kidney malformations, neurodegenerative disorders, head trauma or skull fracture, bacterial meningitis, diabetes, recurrent ear infections, failure to speak at an appropriate age, failed school ear exams, audiograms, environmental exposure, and head and neck radiation. On the physical exam, you're going to do a hearing screening. You're going to complete a physical exam with a focus on the eyes, the skin, the skeletal system, and the nervous system. You're going to assess the ears and look for preauricular pits, any auricular malformations or appendages, any abnormality in the tympanic membrane, and any mobility issues in the tympanic membrane. For eyes, you're going to assess for cataracts, any corneal opacities, any blindness, nystagmus, bulging eyes, night blindness, iritis, blue sclera, and any craniofacial abnormality. Diagnostic studies would include detailed testing for the newborns for hearing, audiometry for children. Differential diagnoses may include cerumen impaction, infections, otitis media with perforation. Management includes referring to an audiologist, a surgical intervention if necessary. It's important to treat the underlying conditions, do genetic counseling if indicated by certain anomalies. The child may need some amplification devices to help with hearing. Cochlear implants are sometimes used if the symptoms are and hearing is profoundly lost. Special school or teaching strategies. It's important to treat the medical conditions and have a family-centered approach to managing the hearing loss. Complications, some difficulties with speech and language. There may be cognitive or social development delays. Prevention, it's important that parents are aware of good prenatal care should they get pregnant in the future. Having Rh globulins have indicated, having prenatal and perinatal infection care, avoiding ototoxic drugs, immunizing, and avoiding environmental factors that could associate with hearing loss. And that might be, being in loud environments for the child to have to hear pounding sounds or loud noises. I believe that is the end of chapter 30, and I appreciate your time. Thank you.